حنيفة نبدأ. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. نرحب بالسادة الحضور في فعاليات افتتاح المؤتمر 11 لجمعية القلب الليبية، ونبدأ أول جلساتنا العلمية إن شاء الله. المتحدث الأول هو الدكتور خالد اللافي، الرئيس السابق لجمعية القلب الليبية. هو أستاذ مشارك في كلية الطب جامعة بنغازي and consultant interventional cardiologist. His lecture will be top clinical trials of 2025. The stage is you, Dr. Khalid. تفضل.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أخوة الزملاء, ladies and gentlemen, chairmen, it's my great honor and my pleasure to be with you today and to have the chance to be the first presenter of this highly scientific largest meeting in Libya. أو نقول أول كبوة في المؤتمر. My talk today will be about top clinical trials of 2025. طبعا large topic to cover in 15 minutes. My trials that I'm going to present will be taken from the largest society meetings, ACC, ESC, EuroBCR, and TCT. هذا was only 10 days ago. The reasons to select a trial for presentation, it has to be revolutionary or have significant observation, widespread acceptance, and can change the clinical practice. The trials I'm going to talk about today, okay, it's moving forward. I want to go backward, Parish. Let's go, okay. The trials I'm going to cover today is trying to cover important trials with cardiogenic shock, heart failure therapies, post-MI, antihypertensives, antithrombotic deceleration, structural intervention, basically TAVI, coronary intervention, new drugs for HOCAM, and thrombectomy in pulmonary embolism. Cardiogenic shock trial, we have 3 devices in use. One of them Ambella, intra-aortic balloon pump, and ECMO. First trial to present today is the danger shock trial. The open-labeled trial to use Ambella versus standard treatment in early post-MI cardiogenic shock. The results is that lower mortality at 180 days in the Ambella device group, but that was at the cost of more serious complications, mainly vascular complications. Okay, the second trial, ALT-SHOCK 2, using the early intra-aortic balloon pump support for failure-related cardiogenic shock. Routine use, the conclusion from this study is the routine use of intra-aortic balloon pump plus standard care was not superior or significantly improve management for heart failure cardiogenic shock. So it is a negative trial. The other trial, ECLS shock trial, using extracorporeal life support compared to usual treatment. Again, the risk of death from any cause was not lower in ECLS in comparison to standard. So again, another negative trial. So out of the cardiogenic shock trial, was only positive trial is used with Ambella. Intra-aortic balloon pump and ECLS, they both negative trials. We move into heart failure trials. We have few important topics to cover for heart failure. We have use of DABA, select trial using GLB, digoxin, and IV iron. To start with, using DABA ACT-HF trial, هذه using DABA glufizine in patient hospitalized with heart failure. So using SGL2 in patients at acute heart failure. It didn't show significant reduction for risk of cardiovascular death or worse heart failure. But if we take it in the context with the other randomized controlled trials, it did show all of them together reduce the risk of adverse outcomes. So it can be used now. We didn't use it before, like now we can use SGL2 inhibitors في البيشنت اللي عندهم acute heart failure. Again, it is safe drug and well tolerated by patients. الأذر trial اللي هي select trial اللي هو using ال GLP-1 agonist اللي هو semaglutide في patient heart failure with preserved ejection fraction and obesity but without diabetes. هذه again important trial patient اللي هو ال HFP ejection fraction and obesity. It did show early cardiovascular benefit independent of weight reduction. Interesting finding. And independent of the weight loss that you see with this drug, there is cardiovascular benefit and reduction for total events and heart failure benefit. So again, this is a second positive trial in heart failure. Digoxin. Now, this drug we are not using much now for advanced heart failure. It's back again to the news. A digit heart failure trial, use it for advanced heart failure. اللي هم patient ejection fraction less than 30 plus class 3 or 4, or patient with ejection fraction less than 30 but class 2. Digoxin has been shown in this trial to reduce the risk of all-cause death and hospitalization for worsening heart failure. So again, another positive trial for heart failure. The FAIR H2 trial. FAIR H2 trial using an IV iron improved the quality of life in patients with heart failure and iron deficient. What I mean by iron deficient, it doesn't mean that the patient have anemia. Even patients with normal hemoglobin, this drug has been shown to improve significant results improvement for the primary endpoints. اللي هنا mainly كانت improve the quality of life but not mortality. So it's a morbidity benefit, not mortality benefit. So now in heart failure, in summary, we have 3 positive drugs improve the morbidity more than mortality. DABA, we have select, semaglutide, IV iron, and digoxin. They all positive trials for heart failure. We move now to hypertension. What's new in hypertension? To summarize the recent trials, the resistant heart failure, we have 2 trials, phase 3 trials, mainly using a new drug, novel drugs, اللي هن new aldosterone synthase enzyme inhibitors. They lowered the resistant hypertension by around 11 millimeter mercury. Here 2 trials, BAX-HTN and advanced HTN. هذه BAX-HTN trial is a first in class. طبعا just a slide اللي هي you can see الفوتو there just as a reference. لكن the main results اللي هي down. Baxdrostat is the first in class aldosterone synthase inhibitor for resistant hypertension. It's more selective than the spironolactone and other drugs. It has no potassium elevation and no androgenic side effects. We move from hypertension to myocardial infarction. We have important keynote trials this year using beta blocker. We all use beta blocker routinely in patient post-MI. Now things changed. We examined the long-term use of beta blocker in post-MI patient with ejection fraction more than 50%. Preserve it and no heart failure in my patient هذوما using beta blocker. Should we use it or not? We have four trials. One of them is the Reboot clinic. We'll talk about it, and then we'll talk about colchicine Reboot trial. Beta blockers after MI in patient ejection fraction more than 40. Beta blocker showed no evidence of benefits in patients with MI managed invasively who had ejection fraction more than 40. This is the conclusion from the trial. But subgroup analysis of this trial showed that patients with ejection fraction, mildly reduced ejection fraction, between 40 to 49%, they benefited from beta blockers. And if you take, this is the meta-analysis of the 4 trials, beta blocker useful for ejection fraction 40 to 49, but not patient with ejection fraction more than 50. So we stop using beta blockers for preserved ejection fraction, post-MI. We have colchicine, using colchicine for acute MI. اللي هو عندنا trial clear trial using acute with long term colchicine did not improve the primary endpoint. So don't use colchicine acute in mind. Now, sorry, move here. The title upstairs is wrong. هي Riva War trial. هذه اللي هي comparison between rivaroxaban versus warfarin في البوست MI LV thrombus. It showed that there is no inferiority of rivaroxaban against warfarin في البوست MI LV thrombus. Now we move to an important subject here, antithrombotic treatment. We all used to use the dual antiplatelet therapy for 1 year. Now things have changed. We have studies this year showing that you can use monotherapy after 1 month or short time. We also have a comparison between clopidogrel and aspirin. Now, this is a new mindset, just to set your mind backward. You are using aspirin, if you use aspirin shortly, just for the period of time during the admission, here less than 96 hours, use dual antiplatelet therapy, and then you do stenting, complete stenting, calvert and non-calvert lesions, and then compare between dual aspirin and PU2 inhibitors, or just monotherapy with ticagrelor, for example. Interestingly, the early withdrawal of aspirin after BCI, there's no inferiority, the same. If you use monotherapy after 1 month or dual therapy, the results are same. Very interesting. Again, another trial, target-free trial, same principle, but لكن هنا they used dual therapy for 1 month. الستادي الأولى اللي هو New Mind they used aspirin only for a few days. هذه 1 month of dual therapy, then just monotherapy. Again, the results are same, and so was not inferior at 1 year follow-up. Now we move to this trial اللي هو Smart Choice 3. Smart Choice 3 هذه long term after 1 year of dual therapy or just monotherapy. What should I use? Can I use aspirin or clopidogrel monotherapy? This trial addressed this question. Clopidogrel monotherapy was more effective than aspirin in lowering the major cardiovascular in high-risk patients, and there is no increased risk of bleeding. So interesting. Clopidogrel is better than aspirin after 1 year. We move to another subject اللي هو still في الانتيثرومبوتيك alone AF. Alone AF اللي هو long term anticoagulation. Patient to have successful ablation of atrial fibrillation. Should we continue anticoagulant after 1 year or not? Alone AF addressed this question and found that no need for use anticoagulant after 1 year of successful ablation. Reverse trial, very interesting, phase 3 trial. At the end, now we got an antidote to ticagrelor. We always had a problem with ticagrelor. There is no reverse agent. Now we have a reverse agent that can be used to treat uncontrolled major bleeding or urgent surgery, and it did show very excellent results. We have excellent to good homeostasis achieved in 90% of the patients who they used. Now we move to structural intervention. Mainly I will concentrate on TAVI against SAVR. Interesting trials. I tried to summarize them in 4 slides. We all know that high-risk surgical patient, we know that TAVI is better than SAVR. Now we move to low-risk patient. Now they are asking another questions. Can we use it in low-risk patient comparison between SAVR and TAVI? I will describe meta-analysis of 60 trials presented this year, and then we talk about what about using TAVI in younger patients, and then what about using TAVI in asymptomatic severe aortic stenosis. Okay? Very interesting questions. This is a meta-analysis if we take 60 trials with low-risk severe AS, TAVI against SAVR. The end results is both are same. And there is a tendency, if you look at the slide down, the table showed that there is a favor of TAVI against SAVR. Okay. And now we move to Notion 2 trial, 3-year follow-up. عادل أنا انتبهت النقطة متاعك. You are right. Notion 2 trial. Now we have a 3-year follow-up. 3-year follow-up after Notion. طبعا Notion 2 trial is the first trial to address using TAVI against SAVR in young patient. In young patient اللي هم age 60 to 75. We used to say 75, now we move to younger people. 3-year follow-up presented this year. Both are associated with low rate of valve deterioration and need for renal intervention. But in bicuspid aortic valve, bicuspid aortic stenosis, SAVR is better than TAVI. So if you select a younger patient, tricuspid valve better results than bicuspid. Bicuspid better to go for SAVR. Now we move to this early TAVR اللي هو using التافي في البيشنت اللي هو asymptomatic severe aortic stenosis in comparison to clinical surveillance اللي هو you follow up the patient and see what happened. Interesting in this study, the primary endpoint that patient with TAVI with asymptomatic AS, they did better than clinical surveillance. In TAVI, this is landmark trial. This is a new valve, bioprosthetic valve, a new TAVI balloon expandable prosthesis. Had the Indian-made prosthesis, cheaper than the other TAVIs, and it showed that there is no inferiority in comparison to other prostheses. So this may build up a little revolution in the cost of TAVI. Now, to move to the coronary intervention. Coronary intervention, we have a few interesting trials. One of them is FAME trial. Then we have DCB against DES, orbital atherectomy, immediate or deferred non-Calvert BCI. FAME trial. This is the famous FAME 3 trials. I have just 3 minutes. Okay. FAME trial, open label trial, comparing the FFR guided CABG, BCI versus CABG for 3-visit disease. The end point is that the end results, CABG is better. CABG is better. But if we take subgroup analysis, the patient اللي هو عندهم low syntax score, they did the same like CABG. لكن the end result is CABG better than BCI. Solution de novo trial هذه DCB against drug-eluting stents. The results showed DCB is non-inferior to DS in de novo lesions. Against this other trial, same principle, but HANA did not show any inferiority. So HANA, it showed that DCB, the drug-eluting stents is better than DCB. The end result to take from there, DCB is good for instant stenosis, de novo lesions less than 2.7, or patient to high risk of bleeding. But other than that, you still use DES for de novo coronary arteries. الأموديوم trial, again another interesting subject, whether to do complete, immediate Calvert and non-Calvert primary BCI, or delay a non-Calvert lesion up to 6 weeks. The end results of Immuderan اللي هو same results. If you do it immediately or follow up after 4-6 weeks, there is no difference between both of them. I may skip this one. This is an important BIFORC risk score, important score, depends on the clinical and the lesion characteristics to see whether this bifurcation lesion is low, moderate, or high risk of mortality. Novel drugs في الحكم, you can skip, but I'll just go هنا to stride, effective ones weekly, subcutaneous. Okay, I just take home messages. My two take home messages, cardiogenic shock, Ambella is the best available device. Heart failure, DABA and acute heart failure, digoxin advanced heart failure, and IV iron, positive drugs. Post-MI, no need for long-term beta blockers in patient with ejection fraction more than 50. Colchicine has no place. Rivaroxaban is equal as warfarin. And the new novel antihypertensive drugs we talked about. And then the antithrombotic monotherapy is as effective as dual therapy after 1 month of BCI. Clopidogrel is better than aspirin for long-term BCI. At the end, we have a new ticagrelol antidote. And then we move to the last takeaway messages. TAVI, incomparable, low-risk symptomatic, old age, young age, or asymptomatic TAVI give a good results. Intervention, coronary intervention, just to end up, CABG remains the treatment of choice for complex 3-vessel CABG, coronary artery disease. DCB is suitable alternative to DES in instant stenosis or lesion less than 2.7 or high risk of bleeding. Calcification angioplasty is as effective as orbital atherectomy in calcified lesions. So you shouldn't do routine atherectomy for calcified lesions. Okay, and I finish by here, and thank you very much.
Thank you very much, Dr. Khalid Lafi. Excellent presentation as usual. We will leave the questions by the end of the session. Now we will invite our friend Dr. Ibrahim Badr. He is an associate professor of medicine, Division of Cardiology Department of Medicine, University of Alberta, Edmonton, Canada. He will be talking about application of artificial intelligence in the field of cardiovascular care. تفضل دكتور إبراهيم.
بسم الله. أتقدم بالشكر للأخوة في إدارة الجمعية واللجنة المنظمة واللجنة العلمية على العمل الرائع. So it's kind of a brief presentation about using artificial intelligence in cardiology. I have no disclosure related to this presentation, and we'll cover briefly, we'll go through introduction with some history of artificial intelligence, then definition of artificial intelligence, and what should we know about AI and medicine, and some application mainly on the ECG, but we'll mention briefly application of AI to other tests. So artificial intelligence started in 1950s and started by 1950, 52, 53. They start to teach the machine some intelligence to mimic some activities that's usually done by human. And in 1950s, 60s, and 70s, Dr. Warner, who lived in Salt Lake City, he started like the kind of the first medical records, electronic medical records, which was very important after like in the 80s and 90s now in developing artificial intelligence and use it on the medical field. And all of us, we use AI in different spectrum, our cell phones, cars, computers, everywhere. So in the 1980s, there was the first AI conference held in Stanford, and then there are other things related to AI like driverless car, then AI was used in chess game, and the AI was able to beat Gary Kasparov in chess. And then we had the software for voice recognition, which is it's called Dragon, and a lot of people they use it for dictations and medical letters. And then in 2000, there was the first robot that the face was able to mimic the human emotions. Then NASA, as we know, landed 2 rovers on Mars, and then till we have Siri and Xbox, which was a huge advancement in AI. And since 2012 till 2022, it developed to the point that was able to recognize pictures of animal, human, and to be able to even create poetry and like writing in different language. And most, or like some of us for sure use ChatGPT for different things, different writings. Now, why this happened, as we see over the last 30 or like over the last 50 years, all of us will remember that with the computer, they were slow, they had less capacity, they were not able to process information till later. Then now what we used to need like big room to serve for like information or for capacity, now we can hold it, can be handheld. So what's the definition of AI? AI, it's any technique that allows a computer or machine to do activity or behavior or intelligence that mimic human behavior. And there are 2 main things in that. There's machine learning, which is a subset of AI, and that uses statistical techniques to enable machine to learn from large pool of data. And then deep learning, which is kind of mimic the neurons on the human brain, and thus need a lot of learning, then it become very good in doing like different activities. Why it's more, or like we saw growth of AI in medicine? Because we have large data, especially if they have EMR diagnostic tests, and those large data with the availability, then it become easier to use AI with that. And with deep learning and neural network, it become easier to solve more complex problems. So application of AI in medicine. The AI can perform some of the tasks that physician or nurses or technician they can do, like test interpretation, prognosis, diagnosis, and it can support the undersurface area in some community, like doing ECG or ophthalmology exam, and then the machine can give the diagnosis and sometimes guide us even on the treatment. And with multiple modalities, labs, then it can improve the risk reduction. So this is just this diagram show like what's the importance of taking like the history, EMR, ECG, wearable tools, and then imaging, CT, cardiac MRI, and all of those, they will come to the artificial intelligence and then can help with making diagnosis, can also monitor the patient remotely, improve the decision maker, help us with the treatment choice, and reduce the cost. Initially, it will be high cost, but after that, will reduce the cost on the long term. And to try to explain, it's very hard to understand, but to make it easy, so you have the machine or the computer or the AI machine, then you have your input, you put an ECG or a CT, and then this will go through multiple processes there, and at the end will give you the output, which could be a diagnosis or risk prediction. And with this, they start using this with 12-lead ECG, which is to test if the machine will be able to read the ECG. And the interesting thing, like they had to use hundreds of thousands of the ECG. They usually divide those groups into 3 groups, one for the machine, one for internal validation, one for external validation. And as you see here, the machine was able to read the ECG almost better than like experienced cardiologists in making the diagnosis of rhythm, like AFib, any other arrhythmia, heart block, chamber enlargement, long QT, all of those, as you see here, the dark green, this is the machine compared to the experienced cardiologist. And the machine can highlight those abnormalities, like right ventricular hypertrophy, bundle branch, AFib, if there is any infarction, and to how we test that, we have the RCU curve, which is test if the test is doing like it's like just like random classification. If it's going up, this means the result is very good in favor of those tests. So, and after trying reading the ECG, they try to guess if guess the left ventricular systolic function by just the ECG. So you put the ECG in the machine, then give you the ejection fraction from the other side. And as I mentioned, this need hundreds of thousands of 12-lead ECG, do the same process, learn the machine, and then test it. And still the result is very, very good. As you see, all of this is very, very good, was able to read the left ventricular ejection fraction. But the interesting finding, some of the ECG, when the machine read them as if they have low left ventricular systolic function, those patients, all of them, they had echo within 2 weeks. And the echo was normal, but the machine, initially thought the machine was wrong in reading this. It was very interesting, those patients who has like abnormal ECG read by the machine, the echo was normal, their risk of having cardiomyopathy was 25 to 30%, 5 to 10 years after that. So it looks like the machine is reading small things sometimes we can't see on the ECG. And the data also was published recently in Canadian Journal of Cardiology. Is still the same. Those patients with false positive, they have higher risk of cardiomyopathy in the future. And so you can put the ECG there, then you have either the patient have low left ventricular ejection fraction or normal, and you make your diagnosis. And then after that, they try the same thing instead of 12-lead ECG on smartwatch, which a lot of people they wear, and still gave good result with that. You can make the diagnosis with ventricular dysfunction with a smartwatch. So it's easy, just like down it, and then the AI will tell you if this is low left ventricular ejection fraction or not. And the machine, interestingly, also was able to determine other things, to say if this patient is male, female, what's even the age of the patient. And all of those are consistent, and was able to read the QRS, T-wave, P-wave, all of this, and still the AI was able to determine those individuals' age. Except for very, very young patients, sometimes it's overestimate that, as you see there from the curve, or the patients who are very old, above 80, sometimes the machine or the AI guess they are younger than what they are. And you see it clear on this diagram. So the artificial intelligence can predict the age by, sometimes even by single ECG. And you see the patient age 20 to 29, the ECG age is more than chronological age. Patient after 80, usually the ECG age is younger than the chronological age. And there is some difference in women. Usually give them 10 months younger, which most likely because they develop a heart disease or coronary artery disease later. And then the other question was asked what about one single ECG to predict mortality? And it was good, wasn't bad actually. There's one ECG, most of those patients, they were in the hospital, and then you give the machine one ECG, predict mortality. If you give more ECG to the machine, maybe it's on some result is a little bit better, but yeah, with one single ECG, it's scary to say this patient most likely the prognosis mortality in 1 year will be this. And this will be helpful for patients who have heart disease and their cardiovascular age is younger than their age, so those patients at least we can target for better control of their risk factor and reassess, and maybe some of those at risk of having cardiomyopathy maybe even to start treatment early. And of course, as mentioned earlier, still able to differentiate the AI between the type of long QT, hypertrophic cardiomyopathy, hypertension from hypertension-associated cardiomyopathy from hypertrophic cardiomyopathy, and amyloid, aortic stenosis, and pulmonary hypertension. And they just mentioned the ECG, but there's a lot of work was done on CT, even on cath, on a nuclear test, and still there's very, very good results, but don't have time to cover all of those. This is just to mention this briefly. There's also some for the angiogram, and come to the take-home message. It's a very growing field in medicine. It may predict outcome, help us with the AI may help us with making diagnosis, or even predict if those patients are at high risk of having cardiomyopathy or even cardiac death, but need to be implanted in a proper way. As I mentioned earlier, you need very strong internal validation. You need electronic records, and you need everything to, and the images, so you need working system to be able to get to that result. And it may help us with making medical decision. Hopefully it's not gonna replace us, And if you can play this video, Cam. Oh, there's no. Thank you. Try to stick with them.
Thank you, Dr. Ibrahim. It's an instant, very excellent lecture. And I'm honored to introduce Dr. Salim Yunus. He's an assistant professor, University of Manitoba. He's a director of a nuclear medicine department, diagnostic imaging service in Canada. Dr. Salim will speak about establishing a nuclear cardiology program in Libya. The stage is yours.
Assalamu alaikum wa rahmatullah. Thank you very much. We're going to speak about how to establish a nuclear cardiology program in Libya. I have nothing to disclose. We're going to talk about the site and layout plan, the equipment, the radioactive supplier, staff requirement, radiation survey, and licensing. Usually when you plan to do any construction for a nuclear medicine department, you have a certain area you have to cover, including the source storage, the source preparation, the dose administration, isolation ward, and the radioactive waste storage. Then you have to submit your plan to the competent authority, and once you get the approval, you start your construction. This is a typical design for a nuclear medicine department. It's usually done in any diagnostic imaging facility. It's usually in the main floor beside the emergency department with the radiology program. We have two areas. We have the cold zone area and we have the hot zone area. Usually start with the general reception. You have the physician room, you have the general toilet, and you have the technologist room to process the imaging. You have the place where you're gonna put your camera, and after that you have the hot zone region where you have the hot lab. You prepare radioactive materials, then after you discharge your patient, you keep them in the waiting area, and then they're gonna have a smooth exit from the outdoor. ما فيش ما تطلعش الصورة في البروجيكتور. Now, this is the key area zone, the cold zone area. You have the reception area, the changing room, and the general waiting area. And you have the hot zone region where you're going to have the hot lab, the injection room, the imaging room where you're going to put your cameras, the SPECT-CT, PET-CT, or PET-MR, and then you have another room for the radioactive waste storage. When you have your patient, they're gonna come through the reception, they're gonna go to the injection room, and they're gonna go for the imaging. After that, the post-injection room, and they get out. This is one component. The second component would be the radiopharmaceutical workout, where you're gonna have to prepare radioactive material to inject to the patient and how to administer to the patient. And in the last component, you need a place where you're gonna receive your radioactive materials, you collect them, and you put them in the waste room. Three components for diagnostic imaging. We have level 1, level 2, and level 3. Level 1 usually for basic camera, which is the gamma camera for nuclear medicine. Level 2, usually we introduce the second part, which is the SPECT images, which is the more advanced images. And the level 3, where we have the most advanced technology, like the SPECT-CT, PET-CT, and PET-MR. This is an example for the SPECT and gamma cameras we use in our department. And this is a PET scanner, and right now we have the hybrid imaging systems, including PET-CT, SPECT-CT, and PET-MR. What's the idea of the SPECT camera? You bring your patient, you inject them with your radioactive materials. They're gonna emit photons. Those photons will be exiting and going to create a light through the sodium iodide crystal. After that, you have the photomultiplier tubes where the light will be converted to an electronic signals, and the signals will be imaging in our system. The same idea for PET, but PET has what we call the annihilation photons. The positron will interact with the electron, and they will have an annihilation effect, and they will eject two strong electron or annihilation photons with 511 keV, so that 511 keV will help us to eliminate a lot of attenuation artifact. And this is the advances of PET-CT over SPECT-CT. We use the sodium iodide crystal for the SPECT camera. For the PET camera, we use the LSO or the LYSO crystal. Example of the most advanced PET-CT camera in our department. Now we're gonna go to the hybrid imaging, which is the new technology, the more advanced one. What's hybrid imaging? Meaning you have the physiological function, which is the SPECT images, and you add the anatomical function, which is the CT imaging. So you have the function and the anatomy, and that will help to guide you with more precise localization for any lesion in the body. The most advanced one, PET-CT, currently used for oncology, and we have the SPECT-CT, which help for anatomical localization for any imaging. This is just a simple example. In the middle, you have the PET scan. On the left side, you have the CT scan, and on the left side, you have the PET-CT image. You have the function and the anatomy at the same image. Most important for your project is the cardiac camera. The main type is we have a SPECT and PET cameras. What SPECT and PET, usually we measure the coronary flow. If you have any obstruction in any of your coronaries, you're gonna see that filling defect with reduced blood flow. If you have a good perfusion, you're gonna see the healthy blood flow to that area, and that's how we see that in the images. The most advanced SPECT cardiac camera right now using the cadmium zinc telluride crystals, which help to improve the image quality, and you have a faster imaging. The most common cardiac SPECT camera in the market field right now, we have the GE Discovery NM530. We have the Spectrum Dynamic D-SPECT cardiac camera. You can see, you can bring your patient, have him sit like he's sitting in the chair. You do your imaging, and you have the image. And the most recent one, we have the Spectrum Dynamic Vitron with CT, because we can right now localize extra cardiac finding. We can inject radiotravers, can be picked up by other parts in the body, like for myocardial perfusion scan. You inject them with system maybe. With the CT, sometimes we can discover extra cardiac like adenocarcinoma of the breast, and the CT help to localize that lesion as well. This is a chart of the comparison between the SPECT and PET cameras, including image quality, the speed. They have faster speed, more or less radiation dose, because the more advanced technology, the higher sensitivity and specificity of your cameras, it helps to eliminate the radiation dose, and you will have a faster scan time. This is an important part. I wanted to talk about the cost. This is our recent SPECT-CT camera in my department. The billing term is 25% down payment, 65% at delivery, and 10% after installation. The cost of the most advanced SPECT-CT gamma camera is $863,000 Canadian, which is $650,000 US. This number is the actual number and the most recent number from my department. And the reason for that, because that's where some of the politics happen. I heard from my friends here that this $500,000 or $600,000 cost right now, it's in our market here by $5 to $6 million. When you buy a new SPECT or PET-CT cameras, other than the cost of the price, you have the service contract. The service contract of any camera, usually 7 to 8% from the total cost of the camera. So if the camera is 600,000, you will pay every year approximately 50 to 60,000 only. You don't need to pay more than that. Here I hear they pay almost half of the price of the camera every year. So this is an important part. You need to look for your vendors. You need to look for how many vendors you have. You need to propose RFP. After you receive the RFP, you need to have good comparison, and you are gonna get a good price for that. I put that from the actual contract I received in my department, and you can see it's a nuclear medicine 870 DR spec CT gamma camera. Now the other part of the nuclear medicine facility, how you're gonna create the radioactive material. We have two sources to create the radioactive material. First one is the generator, which is a device that produces short-lived radioactive nuclei from a longer-lived. The most common radioactive material we use for cardiac imaging, the system IBI. The technetium usually comes in generator. It's the decay of the molybdenum to technetium. And these technetium can be used. The most common examples for the technetium is the technetium molybdenum generator, which is for the SPECT cardiac imaging. And we have the strontium rubidium generators, which is for the PET CT imaging. This is an example of the generator. Usually it's shipped every week from the vendors. So in the past, used to come from Tunisia, from Malta, from Egypt. It's easy, it's handy, can be shipped to your department once every week, and you have the decay of the molybdenum to technetium to use with other tracers. The second part we call the cyclotron. These are not shipped. These are usually on-site cyclotron, which is used to create a short-lived radioisotope. Most common type is the F18 fluorine, which we used for FDG oncology, and we have the N13 ammonia, which we used for cardiac PET CT scan. These 1 or 2 cyclotron in Libya will be enough to cover the whole country, because the short-lived, the radioactive half-life of the F18 fluorine is 118 minutes. It's approximately 2 hours. Usually, I don't have cyclotron in my facility, so it comes from the closest region to mine, which is about 4-hour driving from my site. So here you can ship it by air from Tripoli to Benghazi, or from Benghazi to Sabha or to Kufra within 1 or 2 hours. So even 1 cyclotron in Libya will be enough to cover the whole country. 2 cyclotron will be perfect. You need just to spend the money on the good resources to have a good facilities in your country. The hot lab, which is the place where you're gonna do your radioactive materials. You prepare your radioactive materials, because when you have the technetium, we use to label with other tracers. For cardiac imaging, we use to label with system IBI or MyView. For HIDA scan, we use to radio tracer to label with other radiopharmaceuticals. All this will be done in the hot lab. We use the ring badge. You need it in your department to measure the activity in your hands, in your body. Use the dosimetry, which is with the pictures you can see it's a small sample material. It can be easily purchased and used in your department. We have the dose calibrator, which measures the dose activity before we insert it to the patients. And we have the lid shield, which is where we keep the syringe before we inject the radioactive tracers to the patient. As you see from the pictures, small instrument, easily to manage, easily to move from one side to one side, and it must cost money to the country or to the city. What do you need for your nuclear medicine department? You need a nuclear medicine physician, a nuclear medicine physicist to do the QC, to look at the cameras. You need a nuclear medicine technologist. They have to accept the patient, do the imaging, process the imaging, and send it to the physician. And you need a radiation safety officer who will cover the radiation aspect of the department to monitor any dose or anything. Radiation detection and monitoring, these are the devices we use. We have the Geiger-Moller counter to measure the low-level radiation contamination in your department. We have the gamma probe parathyroid scan. Sometimes the physician takes this probe, we inject that with the material, and they go in surgery to localize exactly what the parathyroid adenomas. We have a personal dosimetry, usually borne by the staff to measure the radiation exposure. And we have the area monitor to monitor any radiation in your department, because at the end of the day, one of the technologists will have that area monitor to go to the department to measure any spills or any radioactive material. You have to keep the records in your department for any procedure you do, any radiation safety record, any individual record for radiation order, the TLD, we wear it. After 1 year, the radiation safety officer will come, will pick up those TLD from us. He will measure the radiation or the activation, and he will send us the final document, how much radiation we exposed, and we have to certain levels. Usually with the new advances, we are low and very low level of activity usually detected with the TLD, which is promising and good for any department. Usually we record any significant event, any action taken for any spills or anything has to be recorded in your department. And at the end, for how long we keep those records, we keep them for 5 years. You have to keep your records in your department for 5 years. Licensing, this is very important aspect. You cannot open any nuclear medicine facility without license. There are 2 types of license. There's the medical professional license, and there's the regulatory license for handling radioactive materials. These licenses provided by competent authorities, like in Canada, it's the CNSC, which is the Canadian Nuclear Safety Commission. For US, it's the NRC, which is the Nuclear Regulatory Commission. Very important. After you have the license, you can start your program. My take-home message, we don't need to be like other countries in the world. We need at least close to them. Any diagnostic imaging department, they have 2 umbrellas, which is radiology and nuclear medicine. We have radiology almost everywhere in Libya, but unfortunately we don't have a nuclear medicine facility. I hope you start so we keep us, because the future is for the functional imaging, SPECT-CT and PET-CT coming, and you need to start as soon as possible, and thank you.
Thank you, Dr. Salem, for this interesting presentation. Next presentation هو actually حتاخدنا في رحلة عبر التاريخ. لمحة من تاريخ عظيم وعبقرية سبقت عصرها لعالم عربي خلده التاريخ. ابن النفيس. It will be explored by Professor Jhani, Professor عبد الرزاق جهاني. Professor Abdul Razak Jhani, Senior Consultant Intervention and Cardiologist, Chairman, the Heart Center, Chairman, the Heart Center, Professor of Medicine, Cardiology at Qatar University, and Weill Cornell Medical School, New York. He is Fellow of RCB, UK, Fellow ESC and ACC. Professor Jhani has several awards, including the Young Investigators Award of the American College of Cardiology and the Crum Lectureship Award of the Royal College of Physicians. He is the editor-in-chief of Qatar Medical Journal and the program director of the National Primary PCI and of the Advanced Life Support Program. My pleasure, and allow me to invite Professor Jhani to explore history of the human circulation, the pioneering work of Ibn Nafis, 300 years before Harvey. Professor Jhani.
Assalamu alaikum, bismillah, alhamdulillah, wassalatu wassalamu ala sayyidina rasulillah. First of all, I thank the organizing committee for giving me a second chance to give this, I believe, very important lecture. And second is thank you for my previous speakers who have given us a very good look at the future. I have to take you into looking backwards in the past. I'd like to talk about one of the most important physicians of all times, and certainly the most important cardiovascular physician of the Middle Ages, when Europe was in darkness. Yet this man has been denied, has not been acknowledged as he should, and I hope I do him some fair tonight. I have nothing to disclose. My interest with Ibn Nafis started when I was medical school, and a great physician who is one of the Reuters of Fulco and Neil Physiology displayed an important slide, and he asked us who is the first to accurately describe the circulation. and he answered this to our Sheikh Ibn al-Nafis. Yet when you look today at who was the first to discover circulation, you look at Wikipedia, American Heart Association, Britannica, National Institute of Health, you will always find William Harvey. Even as recent as 1219, the chief editor of Circulation Research wrote this amazing thing. He wrote that in 1628, when Harvey published Motu Cordis, the medical world was still under the purveyance of Galen. This is as recent as 2019. Well, there are some important questions that we have to look at. Number one, did Ibn Nafis describe circulation 300 years before Harvey? Was the original manuscript, where is the original manuscript? And is it accurate? Furthermore, how did Ibn Nafis manuscript reach Europe? And where did Harvey himself study? What were the textbooks at the time of William Harvey? To do this, I spent about 6 years in research between the Malcolm Institute in London, where there's a special section about the original manuscript, and it's by appointments only, the Alexandria Library, the Bruchian Library in Berlin. And with all these, you have to deal with the very traditional librarians who are very stiff and very rigid, very serious. Well, we'd like to talk about life of Ibn Nafis, his work, how he first described the circulation, and how his work was translated and reached Europe. And also, very important to look at the time when he lived. Was it a time of peace, or was it otherwise? And now his legacy and rediscovery. His full name is Ala ad-Din Abu al-Hasan, but I'd like you, very important, to concentrate on Al-Qarashi, not Al-Qurashi. He's not from Quraysh, he's from Qarasha, which is in Syria. And this name is very important if you want to look at the manuscripts in the West, because you will not find it under Ibn Nafis. You'll ask him for Ibn Nafis, you may get one manuscript. It is Al-Qarashi who you should look for. He was born in Damascus at the time of Saif ad-Din al-Ayyubi, the brother of Salah ad-Din al-Ayyubi. He never got married, and maybe this is the reason for his success. And he died at the age of 80, and he did not train to be a cardiologist. He trained to be an ophthalmologist. At the age of 26, when he graduated from then medical school, he became the chief ophthalmologist and Nasiri, Bermistan. Bermistan means hospital and medical school. And soon he became the chief physician in Mansouri, and then the personal physician of Sultan Baybars in Cairo. He lived only in two places in his life, Damascus and Cairo. And for both, he has a story. Now, where do we place Ibn Nafis in all this? If you look in Hippocrates 5 centuries before Christ, peace be upon him, and then Asto, you'll find little physical medicine, lots about the Hippocrates oath and ethics and all that. Real medicine, physical medicine, started with Galen just 200 years AC, after Christ. Well, Galen is an important figure because it's Galen's theory that dominated medicine for a long time until Ibn Nafis. Galen was a Greek physician, but he was thrown out of Greece because he had problems there, and he lived in Europe, Rome, and he became the personal physician of Marcus Aurelius. And I'm sure you know Marcus Aurelius' Arch in Tripoli, a beautiful monument, especially when you compare it with, to me, less beautiful monument of Marcus Aurelius in Rome. At least it's more straight. And after Marcus Aurelius, very wise emperor, he was also a poet and a wise man, came a very spoiled son, Commodus, who ruined Europe and nearly caused the decline of the Roman Empire. And when he was assassinated, 5 emperors, to show you how much turmoil there was, 5 emperors were either assassinated or deposed until came the savior of the Roman Empire, no more than Septimus Severus. Septimus Severus, as you know, he was born in Libya and died in York, in the UK. And this is, for those who visited the Leptis Magna today, this is the arch of Septimus Severus. Okay, where does Ibn Nafis stand amongst the Arab Muslim physicians? Well, first started with al-Razi, who was merely a general physician who looked at public health more than anything else. Ibn Sina was a great clinical physician, but he had held the same wrong theory of the heart as Galen. It was Ibn Nafis, about 4 centuries later, that clarified the circulation, 300 years before William Harvey, and we'll expand on this. What were the concept of the heart and the circulation before Ibn Nafis? Well, interest in the heart started a long time ago. In the Egyptian civilization, we had the mummification, and they mummified everything, and they put them in jars like these, believing that the person will be brought to life for judgment later. And they have put these all in jars except the heart, even the brain. They took it out and put it in jars, but the heart, they left it in place because they believed that in the day of judgment, the heart will be weighed against the feather of Mat, the king of death, and if it is lighter, the heart is lighter than the feather, he goes to paradise, and if it is heavier, he will go to hellfire. Well, if you look before William Harvey, and this is theory held before Ibn Nafis, and this theory held all the way to Galen, and even at the time of Ibn Sina, they knew that there are veins and arteries existed. They believed the veins carried blood, but they believed the arteries were empty, perhaps because when they did post-mortem, they found the arteries empty. So they thought arteries carried air. What is the job of the lungs then? They thought the lungs are just fans to cool the body. This is Galen's theory. In short, he believed that the blood reaches the right side of the heart through the veins and then goes through invisible pores through the septum into the left side, because he couldn't understand how the lung functions with the heart. And the heart, the blood is mixed within the heart, the air mixed with air in the heart itself. Again, he couldn't think of better job for the lungs than to be fans to cool the body. Well, here is Ibn Nafis' original manuscript. You will find it in a book called At-Tashrih Kitab al-Qanun Ibn Sina. It's commentary on Ibn Sina's Qanun book. And as I said, if you look, you always find Al-Qarashi. You don't find Ibn Nafis. So if you want to do serious research about Ibn Nafis, look at Al-Qarashi. This is part of the original manuscript, and please, I'd like you to read it carefully. He talks about At-Tajweef Al-Ayman, the right cavity, which receives the blood, and this blood must go to At-Tajweef Al-Aysar, the left ventricle. And there are no pores between those two sides. The blood must go through the lungs to mix with good air. That is so amazingly accurate. Not only that, if you look at the description of how he describes the pulmonary vein and the pulmonary artery, he doesn't call them pulmonary vein, pulmonary arteries. And in fact, I believe his description is even more accurate. He calls the pulmonary vein the arterial vein, arteria venosa, if you like, in the literature. It's an artery because it goes out of the heart, and it's a vein because it carries deoxygenated blood, unoxygenated blood. And then he calls the pulmonary vein the venosa arteriosa, which the venous artery means it's a vein coming to the heart, but it has oxygenated blood. This means that he did not only realize the flow of the blood, but he realized the contents of those vessels. Such an amazing thing from simple observations at the color of the blood in those two vessels. Well, how did Ibn Nafis' discoveries go to Europe? 300 years after Ibn Nafis, Europe started to wake up in a so-called Renaissance from its dark ages. Two brothers called Albago brothers, both Italians, They translated a lot of work from Ibn Sina, Ibn Nafis, from Arabic into Latin. These two Italian physicians traveled to Syria. They stayed 10 years to learn Arabic, and then another 20 years to translate many of the books of medicine. And they translated a large number of things. But they were honest. And if you look at the original manuscripts of Albagos, they say, this is for Ibn Nafis, this is for Ibn Sina, this is for Al-Razi. They were so honest, and they must be, people must be recognized for their honesty. At that time, there was great places of light and science and knowledge. In Baghdad, there was Dar al-Hikmah. And then, as we see here, there was a lot of transmission of knowledge between Cairo, Baghdad, and Damascus and others. Brothers of Albago went to Damascus and to transfer this knowledge to Europe. But I found another route where Ibn Nafis's manuscript went to Europe. That is through Spain, Andalus. Who was that? It was Michael Servetus. Very interesting man with very interesting story. He wrote a book called Islah al-Masihiyya, or Correcting Christianity, because he believed in one God. He did not believe in Trinity. And this is what put him in conflict with the church. He wrote this book, and in this book he included description of the circulation. Read that description, and you will find this is where Michael Servetus lived and mixed with Muslims in Andalus, and he was influenced by the monotheism of the Muslims. 6 years after Albago, Michael Servetus published a book we talked about, and in that he put a description of the circulation identical to Ibn Nafis. That's not what I'm saying. This is what professors like Professor Meroff, a very great historian, and in that he published a book called Studies of Medical Arab Medicine, and he wrote, the words used by Michael Servetus were the perfect Latin translation of the words of Ibn Nafis. This is testimony of a great historian, and you can find that, by the way, it's published in Annals of Surgery in 1936. Unlike Albago brothers, Michael Servetus, for some reason, did not ascribe the description to Ibn Nafis. He ascribed it to himself. And because of his theological conflict with the church, he was burnt alive with the book tied to his foot. This is a picture I took in Geneva in a street called Max Servetus Avenue. And this is Michael Servetus just before he was burned. And this tablet documents that event. Well, let's come to 300 years later, to come to William Harvey. As I said, again, William Harvey everywhere in literature of today. And I showed you even the 2019 by editor-in-chief. This is the Motu Cordis book of William Harvey, where he described the circulation. And as I said, Europe was steaming of the books of Ibn Nafis, Ibn Sina, and the others. And where did William Harvey study? He studied in Padua, University of Padua. At that time, Padua was like Harvard today. And this is an old picture of the University of Padua, and this is recent when I visited it to look at the library. And this is the library. It's called the Staircase Library. It's also used to be the anatomy place. At the bottom there, they used to make the dissections, and people watched from around. Well, let's look at Donald Campbell in his book, The Arabian Medicine. What did he say? He said, it is beyond doubt that the manuscript of Ibn Nafis, Ibn Sina, Ibn Nafis, Al-Razi were standard textbooks in many of European universities, including, another page, including Padua, where William Harvey studied. Let's look at the Professor Mieli, the Italian professor of history, where he says, we believe, here thereof, that it is fair to ascribe or attribute the discovery of pulmonary circulation to Ibn Nafis, who is the founder of physicians of the 6th century Italian schools, and of William Harvey 3 centuries later. Now, if you look closely, by the way, the Morbus Cordis of William Harvey, you find interesting statements. One of them is this one. He said, just as the blood sent through the lungs, pulmonary artery from the right ventricle returned to the lungs through the pulmonary veins into the left ventricle, as previously described. As previously. Unfortunately, he did not have the courage to say it was Ibn Nafis. Well, this is, as you know, the famous picture of William Harvey presenting the circulation to King James I. This is the illustration he used. Well, Ibn Nafis, it's very important to see when he lived and what world was it like. He lived when there was turmoil of wars, not very much dissimilar of our day today. At his time, I always believed that the Mongols and the Crusaders came into different times. It's through Ibn Nafis that I learned they came from the east and west together. As you know, Holako destroyed Baghdad in 1258 when Ibn Nafis was 48 years old. And Ain Jalut, which is where the Tatars were defeated, was at the time of Ibn Nafis. I'm sure you have seen the surrender of the Crusaders of Jerusalem to Salah ad-Din, and this is actually in a museum of Rome. And I'm sure you've seen all this in the Kingdom of Heaven. One of the important persons Ibn Nafis had to deal with was King Louis IX. King Louis IX led the Crusades, and he was captured in Al-Mansura, as you know. He was badly injured, and he was put into this prison in Cairo. And it was Ibn Nafis who treated King Louis IX. Louis IX was so grateful for this good treatment, he came back with another crusade. Not only that, he is made a saint. I'm sure people in the US know St. Louis, the city of St. Louis. It's named after Louis IX. Ibn Nafis did not limit himself to discoveries. This man is genius. He looked at many other things. He looked, for example, at the coronary arteries, and he said, all Galen, Hippocrates, and even Ibn Sina, they said the heart is fed directly from the blood inside the ventricles. Ibn Nafis said, no. The heart is وجعله ابن سينا. He refers to Ibn Sina. للدم الذي في البطين الآن منه يتغذى القلب لا يصح البتة فإن غذاء القلب إنما هو من الدم المنبت فيه من العروق المثبتة في جرمه. Coronary arteries. And this is, if you want to translate it, and his Ibn Sina's statement that the blood in the right ventricle supplies the blood to the heart muscle is not correct at all. The heart is fed by blood flowing in the vessels related to the muscle, coronary arteries. Now, if you remember at the beginning of my talk, I said that Ibn Nafis was trained to be an ophthalmologist. He did not train to be a cardiovascular physician, and he did not forget that. He is one of the first to describe the optic chiasm. Before Ibn Nafis, or before the time of Ibn Nafis, they thought the fibers crossed to the opposite side only. It was Ibn Nafis who was one of the first to say that part of the fibers crossed to the same side and part crossed to the other side. And this is the manuscript of Ibn Nafis where he describes وفي الحقيقة فإنه ليس كذلك بل ينفذ إلى العضو الذي إليه على غير استقامته. He says, but the reality is not so. The nerve goes to the side that is not in straight correspondence. He's one of the first to describe the crossing of the chiasm. Ibn Nafis published widely. In fact, many of his manuscripts were burned where in Al-Andalus. When Fernando and Isabella took over, they burnt 1.2 million manuscripts over 18 days of fire. Many of them are manuscripts of Ibn Nafis and Ibn Sina and others. This is some of the books that Ibn Nafis published. When you find sharh means commentary, it means that he is actually making comments. In fact, he's being polite. He's making corrections of previous manuscripts. But he's so polite, he says commentaries rather than corrections. For example, even Ibn al-Qanun to Ibn Sina, he made many corrections, one of them about the heart. Where you find kitab, this means he has originally the author of the first book, Kitab al-Shafi and so on. Some of the books are very interesting. For example, book number 11, the minorities or the minute details in medicine. He talked about, for example, the change of color of nails. What does that mean? The change of color of the inside the eye and what it means. You find that in. You find also the book about al-Aghdiya and medicines, foods and medicines, and you find another book called al-Hiyal, kitab number 14, Raqa'i al-Hulal. He talks about clinical tricks to demonstrate the diagnosis. He talks about a child who had a hip problem, but he pointed to his knee so that they don't examine his hip. You find it in this book. He talked in details about clinical medicine. Such a great physician with great acumen and great observation accuracy. As I said, when you find sharh means it's a commentary. He's commenting about other people's work. And when you find kitab, his book, means that the book is written. Perhaps the most important three, if you want to read about Ibn Nafis, are these three. Tashrih al-Qanun Ibn Sina, which contains the description I showed you of the circulation. The other one is Conscience Aspects of Medicine, which is actually the summary of the third book, the Encyclopedia of Medicine, Ash-Shamil fi al-Tibb. Ash-Shamil fi al-Tibb, I found this manuscript, by the way, in Stanford University. Anyway, this is translated. And again, if you look at the top, Al-Qurashi, Ibn Hazm Al-Qarashi, not Ibn Sina, Ibn Nafis. And when all the physicians, all the authors in all fields, when they wanted to write a book, they start by the index. They write the index of what they're going to write. 1, 2, 3, the mujalladat, the volumes. He wrote 80 subjects he was going to talk about. And many of these found in Oxford, but the one I found is in Stanford, California. And he lived only, he wanted to write 300 volumes, but he lived to write only 80 volumes. I wish we had the chance to see the other 220 books. As the great physician Starling, the Starling Law, the great physician Starling once said, the physiology of today is the medicine of tomorrow. Indeed, if there is so much medicine available today, one might say it all originated with physiologists like Ibn Nafis. When you read Ibn Nafis' manuscript today, honestly, you feel it was written yesterday from its accuracy. Ibn Nafis died at the age of 80 in Cairo, roughly 878, and he donated all his books and even his house and his library to the Mansouri Medical School in Cairo. In conclusion, Mr. Chairman, ladies and gentlemen, Ibn Nafis was the first to accurately describe the human circulation 300 years before other physicians, including William Harvey. His discoveries were translated and transferred to Europe through I've identified only two, maybe there are others, I identified only two. Through the Albago brothers, the Italian physicians, who transferred them from Damascus to Europe, and they were good enough to say that they are Ibn Nafis's manuscripts. And from the West, by Michael Servetus, who, as you know, was burned alive because he said so. It is therefore fair to say that Harvey has expanded on Ibn Nafis' discoveries. That should not be denied. But it is fair to say that Ibn Nafis deserves the title of the real father of the human circulation. There is a lot to be looked at in the heart. There's a lot of evidence now to say that the heart is somehow involved with the brain in the comprehension of meanings of things. The brain may have something and the heart something else. And that is what Allah said, Bismillahir Rahmanir Rahim, أَفَأَلَمْ يَسِيرُوا فِي الْأَرْضِ فَتَكُونَ لَهُمْ قلوب يعقلون بها أو آذان يسمعون بها فإنها لا تعمى الأبصار ولكن تعمى القلوب التي في الصدور. قد يقول البعض القلوب يعقلون بها هي المخ، لكن الله سبحانه وتعالى يقول القلوب التي في الصدور. Don't make a mistake. I'm not talking about the brain in the skull. I'm talking about the hearts that are in the chest. The research is open. We're waiting for another Ibn Nafis, perhaps to look at this. One of the greatest statements that is so moving from Ibn Nafis, that would make anybody cry, is this sentence. لو لم أعلم أن تصانيفي ستقرأ بعدي 10,000 سنة ما وضعتها. This is Ibn Nafis. If I thought that my books would not be read 1,000 years to come, I would have never written them. Thank you so much.
ألف شكر أستاذ دكتور عبد الرزاق الجهاني على هذا العرض الشيق والتاريخ الحافل. ألف شكر أستاذنا، وألف شكر للأخوة all the speakers، دكتور خالد اللافي، دكتور إبراهيم بدر، دكتور سالم موسى. شكرا جزيلا. تفضل دكتور.
هل لي في كلمة؟
Yes.
May I kindly suggest to the organizing committees to put a session in future conferences about history of medicine, to acknowledge many like Ibn Nafis who have not been acknowledged over centuries. And it's time for us to pay them the tribute. Thank you so much.
الآن we'll take some coffee breaks and then we'll come back for the opening ceremony at 5. Thank you.